Good evening, everyone, to the 124 or so that have attended the latest RACGP Victoria DHHS webinar on the latest on coronavirus. This is a great opportunity for us to ask DHHS some questions and get some ideas about where we're headed. So just to begin with, I'd like to acknowledge the traditional owners of the land. Obviously, we're all meeting on different lands, and I recognise the elders past, present and emerging. On the RACGP side, there's obviously myself, who is the RACGP Victoria Chair. Off camera, but you'll soon see them, is Dr. Anita Munoz and Dr. Karen Price, who are our Deputy Chairs. As well, in the background, we have Con Cacrith, the State Manager, and Jane Spragg, who's trying to make sure the back end stuff all works and everyone's on as they need to be. Just for some housekeeping, you'll see that there's a control panel on some part of your screen into which you can ask questions. So please ask questions. That's where we get our source material to talk to DHHS about as we go through. There are two handouts under the Handouts tab. You'll see the DHHS slide pack for today, as well as a troubleshooting document from us in the event that you're struggling with sound or something else to do with the system. And also there is a CPD allotment for attending this webinar, so that will happen automatically, we hope. And even if it doesn't, you can also self-report, which is not a problem. So a lot has happened in the 2 weeks since we last met. Victoria's numbers are low, really low, and we avoided those horror projections that were released today and reported into the Age, something like 10,000 projected people in intensive care. So I think it's important that I open by thanking the Chief Health Officer's office and the Chief Health Officer, Brett Sutton, for the work that has led Victoria to this place. I think it is amazing, as Daniel Andrews said, that we're sitting here arguing over whether we can play golf rather than where we're going to put our emergency hospitals and tent hospitals. So that's an awesome achievement, and I really want to thank the government and the Chief Health Officer's office for all the hard work that they have done. It's great and well done. Also want to thank us Victorians for doing the right thing when we were told to. And of course to us GPs who have changed our workplaces overnight, where the same change would have taken more than a year. Now, before we go on, I just want to highlight another iterative change that has occurred for us GPs. There is a new bulk billing incentive for patients who are defined as vulnerable. So that definition of vulnerable has sat in the MBS since the start of this, and it has a specific definition that you can look up on the MBS website. So that number is 10981 for metropolitan GPs and 10982 for regional GPs. So that can be added if a patient fits the vulnerable group and you are doing a telephone, video, or a face-to-face consultation for these groups. Although I admit we still have our billing restrictions in place where a lot of other health practitioners have had them released. So look up those bulk billing incentives. I think they were released under the cover of darkness this afternoon. Tonight from the department, we again have Annalise Van Diemen. So thank you again, Annalise. Annalise is the Deputy Chief Health Officer for Communicable Disease, providing expert advice in this area, and has obviously been involved in this from the very start. Annalise works on all of the communicable disease incidents and emergencies and acts as the Chief Health Officer in Professor Sutton's absence, and engages with the sector widely on these issues as they emerge. And importantly, Annalise is a Fellow of the Australian Faculty of Public Health Medicine and the Royal Australian College of General Practitioners, yay, and also has postgraduate qualifications in public health and paediatrics. Now, there is another DHHS attendee, Sarah McGuinness, who we're trying to actually flick online at the moment in the background, so hopefully that works. We've met Sarah before, who's an ID physician, currently holding dual positions as a consultant physician in the Department of Infectious Diseases at the Alfred, and a lecturer in clinical epidemiology at the School of Public Health and Preventative Medicine at Monash. And also on the side, we have Louise Galloway, who is one of the significant managers within the Department of Health and Human Services related to community health, primary care and aged care. So welcome to all of you. Annalise, I want to start by handing over to you to give us an update about the issues that the department sees as significant, and then we'll open up with our questions. Over to you, Annalise.
Thanks, Cameron. Good evening, everybody. I hope you all had a good Easter and had some expired. We can only call a state of emergency for 4 weeks. So the original one, and obviously with all of the directions that went with that, expired on the 13th of April, I believe it was. And so we redid all of those ones, clarified a few more things. And other than clarifying that golf is in fact banned, we haven't made any more significant changes in the last week, and we're really not looking at a significant decrease of those yet until quite a number of preconditions are met. So for any of you who are following national cabinet outcomes or other things, there's at the moment the major piece of works that are going on is figuring out what the preconditions might be across a really broad range of the outbreak management profiles. So all the way, I suppose, from making sure we've got our testing really specced up as much as we can, making sure we've got enough PPE, making sure we can interview each case, do the contact tracing, do the outbreak management, as you know, in really tight time frames, and that we've got the surge capacity to surge up again if case numbers get up, start to go up unexpectedly again, across looking at other broader community surveillance, looking at obviously making sure the hospitals and the rest of our health system is still ready to go if things do increase again. So there's really quite a broad series of works going on now to really cement the stuff that has been scaled up really quickly using whatever resource we could find and from whomever could offer it, to something that's more sustainable, that will be really cemented before we start thinking about lifting any of those restrictions. So I might go on to the next slide if that's okay. Oh, that's not, I might just skip. No, those ones aren't hugely useful actually. So the testing centres that were established are still going, but I understand now that there are some of the private pathology providers are starting to stand up some specified testing areas as well, which is great. And obviously with the broadened criteria, I think it's really important that everybody who wants to be able to test can do so in a safe manner. As we discussed, the biggest change since we spoke last is the broadening of the testing criteria to anybody with respiratory symptoms or a fever that doesn't have another obvious cause. And I would encourage people to test widely if you think somebody has symptoms, because we're at the point where we really do want to know what's going on in the community, so that we can sort of make some further determinations about what's appropriate to consider for relaxing in terms of the current restrictions, and what's not appropriate. So I'm not sure there's, oh, there you go. So I'm not sure that the final slide's actually been updated. The materials on the website are being updated really frequently though, so I would advise just to keep an eye out for new things on the website, and if you find any inconsistencies or anything that you're not sure about, please email or call in and we will endeavour to get them changed as soon as possible. I might leave it at there though and take questions.
Thanks very much, Annalise. Just to start off with, I think we're in a remarkable position where we have low numbers of cases, and we're doing, I think you said, 3,500 tests or thereabouts a day. There's a large infrastructure that the state has set up both in hospitals, fever clinics, and with the GP respiratory clinics. Is there any plans as to what is going to happen with that infrastructure, assuming that we still keep the numbers under control like we are?
Look, at this point, we're not looking at ceasing those clinics just yet. We know that the current scenario is great, and further indicators in terms of people turning up very unwell in hospitals, and increased numbers of deaths, which can indicate to us that there is broader community spread than we thought. Those indicators are not showing that, so we're reasonably confident at this point that we've got pretty good case ascertainment, and so the real numbers are that the numbers are reflective of significantly decreased numbers in the community. But really, part of that next tranche of cementing things and really sort of knuckling down for the long haul, but also trying to consider some release to some of the restrictions, is figuring out what needs to remain and what can stop, or what needs to become something that can be surged up again as required. So that is being looked at across the health services as well. So at the moment, we haven't got any immediate plans to shut any of those things, and we're in the happy position where we have to consider it, but it will be a matter of really sitting down and doing some more forward projections as much as we can about what we really should, what's a no regrets preparation decision that we should have just sitting there ready to go or keep running, versus what do we put a pause on or stop if we think things are looking pretty good.
So it seems like very much the message to us is to start testing widely so that we can detect that community transmission if it is occurring, so that you've got the information that can help direct government to as to what the next moves are.
Yep, please do.
So for the 200
those who meet the clinical case definition, I should say.
Yes, of course.
Yep.
A few more people have joined since we started the teleconference. Please write your questions in the box that you'll see on the control panel off to one side. I'm just going to hand over to Anita Munoz for the next set of questions. All yours.
Evening, everyone, and thanks yet again, Annalise, and everyone from the department. I'm going to just ask a series of questions that pertains to PPE. I think that with the announcements that there are going to be more face masks in particular that were made over the weekend, there's a need, I think, for us to be as rational as we can about use of PPE and try and follow the government guidelines on what's required. So my first question is about the advice for immunisation. Could you go through with us, please, what is the advice for using PPE specifically when we're delivering immunisations, just to clear up any confusion that there might be in the community?
Yep, sure. So look, at this point in time, the advice is that a mask and full PPE is not needed, because anybody who is seeking vaccination should be well, and the advice is to screen people via questions about whether they are unwell or have any upper respiratory tract infection signs or symptoms before they are presented for an immunisation. But obviously you can't maintain the distancing in the immediate 30 seconds while you do the vaccination, but to obviously try and maintain that physical distance both in the queues as much as you can in the waiting rooms, and to minimise the amount of face-to-face time with each practitioner as much as possible. But it's not to wear masks or gowns or gloves or gowns or goggles when you're administering a vaccination.
Yeah, so I think because the time that you're spending in the company of that person is so small, then you're not really exposing yourself to that 15 minutes or greater, and you certainly shouldn't be having people come in to be vaccinated if they've got respiratory symptoms. We are aware that with the increase in access to PPE, there may be a return to some elective surgeries, and I know that you may not be able to comment on when that happens, but one of the questions from general practice is if there is enough PPE to allow elective surgery to recommence, does that mean that general practice will also have greater access to supplies? And can you comment on how those supplies will be distributed?
Probably this. I'm not sure which electives. There's definitely discussion about it at national level. I haven't seen the exact proposals for what might go back on the list. Certainly it was done in a stepwise manner, and category 1 elective surgery was never off the list, so it would be, you know, sort of category 2 to start off with. So the kinds of elective surgery that will be not elective pretty soon if it's left for too long. In terms of the distribution, current distribution, I can't comment on what's being planned at Commonwealth level. I know there is ongoing discussion about it. I'm not sure if Louise is there and might have more comments, but I haven't. Yeah, I'm not 100% sure at this point in time, to be honest. But we can chase that up and get that back to you offline if there's been any changes.
On the topic of PPE, if there are GPs who need PPE but don't have adequate supplies, can you give us advice about reusable PPE, about the PPE that people might be creating or fashioning for themselves out of cloth and other materials, and whether the use of you know, those measures is endorsed, or if there's any evidence for them?
I might throw to Sarah if she's able to take this one. Are you able to click over to her at all? Is that going to work?
I think I can talk if you can hear me. Yeah, yep. So I think our current advice about PPE is in cases where PPE needs to be worn, the PPE that should be worn should be medical grade PPE that has been tested. The problem with PPE, such as, for instance, masks that people fashion for themselves, is we don't know the level of protection that it provides. Possibly it provides more protection than nothing at all, but there certainly aren't studies that give us confidence that those, for instance, cloth masks will provide adequate protection. When you're wearing a mask, any type of mask, it's very important to make sure that you're not touching the external surface of the mask. That's both when you kind of take it off and when you're using it. And if you do, you need to obviously appropriately wash your hands. But at this stage, the only PPE we would recommend is PPE that has been medically tested.
And just before I move on slightly from the topic of testing PPE and all of those logistics, we're hearing more and more about the option for self-collect by patients. Could you make a comment about, you know, what's its utility in general practice, given that we do, and in some cases have enough PPE, but perhaps in others we don't? Should we be utilising that method, and what's its reliability?
Sure. So, yeah, I can talk to that. So self-collection, I'm assuming by that you mean self-collection of a nasopharyngeal and or oropharyngeal swab for the purpose of testing. Mm-hmm. Essentially, the evidence for its efficacy comes mainly from influenza studies. And so there may not be a direct correlation here, but the evidence from influenza studies suggests that self-collected swabs are almost as good as swabs collected by healthcare workers, provided that those people are given adequate instruction on how to do the swab. It's a potentially very uncomfortable process to do a swab on yourself. And so I think it's something where the patient would have to be comfortable doing that and would have to feel like they've had adequate instruction. There are a couple of coronavirus testing centres where they are actually doing self-collected swabs, but in those cases the patients are shown a video and then there's a poster that they can look at where they can see how to appropriately do the testing. I guess the main concern with self-collection is that you may not get the same yield because you may not get as accurate a test in terms of sampling the oropharynx or nasopharynx. So yeah, I think the key thing is to make sure that adequate instruction is given.
Just before, thanks so much for that. And I think the devil's always in the details, isn't it? Particularly about instructing people. Just before I hand over to Karen, who's got a series of questions, do we have information about false negative rates on both the self-collect and the clinician-collected NPAs?
No, I don't think we're getting information to that level of detail at this point in time. Most pathology centres are still doing undergoing ongoing it's not validation anymore, but it's quality assessment. So all positives go to the reference lab to be checked, which is why there's been a few reasonably high profile cases about false positives, not necessarily false positive, just different cutoffs and not validated at the reference lab, and they're all sending a number of their negatives for further validation as well, to ensure that their ongoing sort of quality assurance is happening, knowing that these are tests that are normally rolled out over, developed and rolled out over years, not weeks. So it is an area for ongoing discussion, and as is, I suppose, sensitivity when we start to look at broader community-based testing in patients where there's a reasonably low pretest probability to begin with. We have had false negatives in people who we knew to have a pretty high pretest probability, so they were retested and found to be positive. And that's going to be one of the tricky things going forward in terms of what we do about our ongoing surveillance strategy. And do we look at tests that might have a slightly lower sensitivity than we would normally accept, but which enable us to do really, really broad and regular community testing. So that's some of the stuff that we are looking at quite closely at the moment.
Thanks very much, Annalise. I'm going to hand over to Karen now. Thank you.
Hi, thanks Anita, and thanks again Annalise and Department of Human Services Victoria for all you've done, because I think we're all feeling a little bit more comfortable now. I'm going to ask some questions in no particular order from the panel of questions that are coming up from the attendees tonight. And I think one, just to finish off with the influenza vaccination clinics, there was some discussion in the media regarding car park testing and testing in cars. Influenza vaccination in cars. So I'm just wondering if you could make a comment on that, Annalise.
Yeah, sure. So look, I believe some information has gone out from our immunisation team recently to say not to do it for the moment. And I've just had a bit of a chat to them prior to this webinar. We know that WA either have already or are about to roll out some guidance for the safe administration of immunisations in car parks. And I know, even from personal experience, that a lot of clinics are having patients do their post-vaccination wait time, in car parks on dots or, outside with much better physical distancing. Oh gosh, sorry, I've clearly been sitting still for too long. The lights have just gone off. I'm gonna wave my arms and hope that they turn back on again. No. I've just had a bit of a chat to our immunisation team, and they've said the immediate advice not to do it is mostly while we can have a look at what the best mitigation strategies are to make sure that there's no significant adverse events in what is, in terms of administering a vaccine in a non-clinical environment. So they're going to keep looking at what other states and territories and international are doing in terms of safety, but we know it's an important thing to be able to balance that, post-vaccination monitoring time with maintaining physical distancing in waiting rooms and stuff, particularly if a time comes where patients are increasing their presence at the clinics again. So the advice at the moment is perhaps don't do it until we've got some better risk mitigations in place, but that it's not completely off the cards right now.
I guess it would depend if the person is attending on their own or with a person accompanying them too. That would make a difference.
Yeah,
a question from a question from Dr. Philippine Nareen. The Aboriginal community controlled health centres, can they apply to be a respiratory clinic? Is there a possibility of the Aboriginally controlled community health centres, are they able to apply for infrastructure funding?
Not sure about infrastructure funding. There's definitely discussions that have been happening in here about ensuring that we have appropriate numbers and spread of culturally appropriate testing capacity across the Aboriginal community in Victoria. So there's a few things that are in place. So we're looking at ensuring that that Aboriginal controlled health organisations can do testing. So we're looking at making sure that there's PPE provided for some of those clinics. There's also discussions at state and national level about looking at potentially rolling out some of the point of care testing that is happening in other Aboriginal communities across Australia in a couple of pilot sites in Victoria. But there's a pretty strict set of guidance in terms of remoteness and other things to go in with all of that, and we're just trying to balance that with ensuring that the super remote places in other states who have really limited access to larger centres probably are getting some of that infrastructure first. But the short answer to that question is yes, but I'm not sure about the funding bits of it. But certainly there's been a lot of discussion about ensuring that there is enough testing opportunity that it's culturally safe and appropriate.
Okay, thank you. I've got a couple of questions about healthcare workers. Just how many of the 162 healthcare workers you said were mostly travel related rather than community work related? You did say, however, it was around about 50% or so. You're not quite sure the figures, that's fine. But how many of the healthcare workers infected through work were from primary care versus hospital care?
That's a good question. I think most of them were hospital. There's been some related to radiology and some in the disability sector. Sarah might have some more comment, but I'm not aware of any that have been primary care workplace transmission. But Sarah's been a little bit more on the ground in the case and contact space than me.
Yeah, I think purely anecdotal, but I'm not aware of any that have been in primary care per se, that have been acquired through primary care. I know of a couple of primary care practitioners who have been infected by contacts,
Yes.
known contacts, outside the healthcare setting. We are taking this obviously very seriously. We know that people are concerned about the number of healthcare workers that have been infected, and so we're very carefully going through each of these to try and determine if the infection is healthcare acquired or not. That is a slightly delayed process because it involves an investigation, and sometimes people might have possible contacts in and outside the hospital. So we're looking into this with genomics and a whole lot of other tools to really try and determine as best as possible. But as Annalise says, the majority at this stage have been infected outside of the workplace. Yeah.
Okay. And this is sort of following up all along this theme about community acquired transmission. I think you said there were 15 cases most recently in Victoria. Is that right?
So our biggest day of individual case numbers since we increased the testing criteria has been 15 cases in one day, not 15
right.
community acquired cases. Yep.
No. So how many have been community acquired?
So at the moment we've got 136 cases that are classified as locally acquired that don't have any links that have been made to overseas travel or another confirmed case. Yeah.
And of the positive COVID cases, do you have any morbidity and mortality figures regarding even the long-term or potential long-term outcomes for those cases?
Don't have any long-term data because it's still April.
As long as we've got.
So it's on the research agenda to see what some of the longer-term outcomes are. We don't have any of. I mean, we've got not at hand. We've got data on how long people are spending hospitalised cases are spending in hospital. We've got data on how many people were have been in ICU and intubated, and I could have a look now to see how many are currently in ICU.
And
it's not a
the
huge
demographics
number.
of those, Annalise, are we seeing it mostly in the above 80-year-old or 70 to 80-year-old cohorts? Are we?
Yeah, mostly. I mean, we had our youngest death in Australia over the weekend in a 42-year-old. That was in New South Wales. We've had one 55-year-old in Victoria, and this is public knowledge. So
Yes.
But that man was our only healthcare worker he was a disability support worker.
Yes.
So he's been the youngest death in Victoria, but otherwise all of our deaths have been in people over 70.
Yep.
And a lot of the ICUs are people in the older age groups.
So it's as we'd expected at this stage. Dr. Margaret Elder has asked a question regarding healthcare workers again, in a couple who are both healthcare workers. If one is sick with an ERTI, does the other keep working? Because there seems to be still some conflicting advice around what happens to the person who's not obviously sick.
Look, at the moment, it's not a requirement that if one of your household contacts has an ERTI that you stay home. We would recommend that any healthcare worker who has an ERTI get tested straight away, obviously, and that as soon as they isolate until that test result is back. So certainly the sick person must stay home, and we would very highly recommend that they are tested. Obviously, if they're positive, they must get their partner home into quarantine as soon as possible. But at the moment, we know there is still respiratory illness around, and particularly GPs are exposed to respiratory illnesses more frequently. And those who've got the joy of kids at daycare or school will have that kind of thing going around a little bit. So we would, there's no current preclusion to somebody who has a household contact with an upper respiratory tract infection going to work, as long as they're not symptomatic themselves.
Another clarification on the testing criteria. In those patients who present, say, with sinus illness or ear infections, would you test those in general practice for COVID? Would you consider testing those?
So sinus infections that could be, seen as an upper respiratory tract infection, certainly I would probably test those ones, particularly if there's a fever involved. Things that are very clearly an otitis externa or otitis media without any of the other accompanying upper respiratory tract infections, I probably wouldn't. We haven't seen a huge amount of ear infections. The international literature is not telling us that this is the way that COVID presents. Sarah, feel free to chip in if you've seen something more recently than I have. But it's not like your Candida auris or other things which have presented more frequently with ear infections. So something that's pretty clearly just an ear infection, I wouldn't be testing at this point in time.
Okay, thank you. I've got one last question before I hand back to Cam. And this is an interesting question. The public health messaging, Annalise and Sarah and Louise, have you been happy with that? Have you had some more consideration about how that should be managed going forward, given there's a whole lot of public debate and a lot of very emotive public debate? And I guess we haven't gone to the app yet, but there's a lot of discussion around that sort of thing. How do you think as GPs that we can assist you in making sure that message comes through? Or what do you think about the messaging so far?
That is a loaded question.
Yeah, sorry.
That's okay. Look, for the most part, I think in Victoria, at least, the messaging from Brett and the Premier has been pretty clear and consistent that this is about staying at home as much as you can. Don't go to work sick. Try not to touch your face. Be really vigilant with your physical and social distancing. I know, obviously as case numbers go down, there's less urgent things for people to talk about, and people start getting a little bit housebound. They get you know, bored and frustrated and annoyed and want to start doing the things that they've been doing for a long time. And the media is also getting bored, to be honest. They're running out of stories. So people, politicians, media are starting to actively look for ways to trip people up. They're starting to look for controversy. So I suppose in terms of what GPs and others can do to help, I think trying not to, you know, trying to just dampen down those people who are seeking divisiveness and seeking controversy based on minutiae or details, or because, you know, one poor person who answered an email who they thought was from a general member of the public to explain the absolute technical aspects of a legal direction, you know, and that then got published by you know, by a media outlet plus minus another politician. It's, you know, that kind of stuff it's distracting and it doesn't help. You know, the big message is please just stay at home. The overarching thing is, you know, yes, you can, yes, there's a direction there that says you can go out and do exercise with another person. And the point of that is so that people can exercise safely. It's not so that people can go and spend 4 hours on the golf course with their buddies.
You mentioned golf.
Yeah. So look, I hope the messaging is still clear, that the messaging really is we still do just need people to stay out of public and to avoid really, you know, big crowds or large numbers of people. And at this point in time, it does seem like we've got on top of it, but like we've been saying, it hasn't actually changed anything. The virus, we still are, for the most part, all susceptible. There's still no treatment, there's still no vaccine, and the mortality rate, if anything, in other countries is going up, not down. So until we've really bedded down a whole bunch of other things, which means that we can keep on top of it if we do start to relax some of the current measures, it really is stay the course so that we can keep up with this preparation stuff.
Is there any idea approximately when that course will be reviewed? Do you have a figure for triggering when those changes will occur, such as relaxing or the quarantine?
Yeah, look, the current measures are in place for 4 weeks from when they were signed, which was last Monday. So we're working pretty frantically in the background to look at what all of the, you know, what any of the preconditions, oh, sorry about that noise, what all the preconditions might be across the range of things that I discussed earlier, in terms of testing, surveillance, PPE, supplies, contact tracing ability, outbreak management ability, infection prevention and control, what the community's got the capacity to do, all of our health service things, what our case positivity rate across community testing is looking like. So I think, you know, the big thing to remember is that, you know, there's been a lot of sort of song and dance about how many people we've got doing things, but it's been a very, very hasty expansion. So we've still got a lot of people who are quite new, quite green, you know, still just getting their heads around things, and a lot of people who are working on this who've come from other industries and other areas, which then means that once you start opening up other areas, they're going to want to go back to their regular jobs and that kind of thing. So it's about, yes, you know, we just need a little bit of sort of couple of weeks capacity, of breathing space to really cement things down. Yeah.
Thanks so much for answering that question. I'll hand back to Cam now. Thank you.
Oh, there I am. And I'm off mute, which is even better. So there are 220 or so people online. Please continue to ask questions in the box on the control panel. We are actually reading them, and we did see Sally Cockburn, who runs a 3AW series on Saturday evenings, saying, "Oh, we're not all bored in the media," with about 4 or 5 exclamation marks after it. So thanks, Sally. and we are reading these questions and using them. So this might be a better set of questions for Sarah, because this is some of the clinical guidance stuff. We've obviously been watching a lot of the clinical decision making that occurs and that has been evolving during this, from how our hospital colleagues are managing cytokine storms, decisions to put people on ventilators, some of the interesting stories about what signs seem to be prevalent or not prevalent, because this is a disease we don't really know what it looks like. I was just wondering if we could ask a few questions. So the story of ACE inhibitors and the coronavirus having an ACE receptor that it gains access to the cell with. We saw some flurry early on about that. I was wondering if Sarah, you could provide some comment both on us as GPs continuing ACE inhibitors, but also whether it's advisable at this stage to start ACE inhibitors in hypertensive patients. I'm not sure we've got Sarah.
Hi, sorry. Thanks for the question. So I guess there was some concern internationally about a possible link between ACE inhibitor medications and potentially angiotensin II receptor blockers, and potentially an increased risk of infection with COVID and or worsened outcomes. That was around the fact that there is a receptor, so the same enzyme, I guess, that the SARS coronavirus uses to infect the body is the ACE2 enzyme. But at this stage, there's no evidence that has borne out that suggests that there are worse outcomes in people who are on ACE inhibitors. And I think there have been fairly strong statements from most of the international and Australian cardiology bodies that have recommended that patients should stay on their current antihypertensive therapy, and that includes the Heart Foundation. You know, I think in terms of starting someone on a new antihypertensive, the greater concern at this stage is probably that they're on the best antihypertensive for them. And so if that person has, you know, an underlying disease or risk factors where an ACE inhibitor is the best thing for them to be started on, then it's very reasonable to start them on an ACE inhibitor. Possibly we wouldn't do it in the event that someone has acute COVID, but at this stage there's nothing to suggest that that shouldn't continue.
Thanks. The other thing that we've watched since the start of this is the coagulopathies that have occurred in patients that are COVID positive. Can we have I'm just interested in your thoughts on the role of anticoagulation in patients who are early on in their disease if they do test positive for COVID.
So again, I think this is an evolving story. There have been some case reports of increased risk of venous thromboembolism in the setting of acute COVID. I think the numbers are small, and it really is limited to case reports at this point. I don't think that there's any indication for anticoagulation in the setting of COVID. The you know, kind of routine anticoagulation that you might give to someone if they're bedbound, so DVT kind of prophylaxis may be appropriate, but none of the clinical guidelines at this stage are recommending anticoagulation that I've seen.
There's been some data presented from New York around asymptomatic cases, which of course I guess the testing criteria won't pick up. I'm just wondering if you could give us any comment on that, particularly given the data that we've seen from a group of women who were giving birth in New York City, where a number of asymptomatic positives were found. And I guess from my interest in that is whether or not these are actually asymptomatic or just mildly symptomatic people.
Yeah, look, great question. I think it is one of the current unknowns. We know that there are symptomatic, asymptomatic or minimally symptomatic people, but we don't yet know what the role of asymptomatic and pre-symptomatic transmission is. So I think at this stage it's really a bit unclear whether whether asymptomatic people are playing any role in transmission, or in fact they're just sort of bystanders who have been infected but haven't manifested any symptoms. We do know in the pre-symptomatic period, so that's the kind of day or two before people actually develop symptoms with COVID, they can be infectious. And there have been some studies now that have looked at that, particularly in people who are contacts of a known case, where they've tested them doing usually nasopharyngeal swabs every day to see when they become positive, and PCR positivity starts 1 to 2 days before onset of symptoms. And so we know that there probably is some pre-symptomatic transmission, but how significant that is, we don't yet know.
One last question. There was a story over the weekend about a particular doctor in Geelong whose family originally came from Southeast Asia, who was subjected to some fairly ordinary racism in a takeaway shop. I was just wondering if we could have a comment to all of us from DHS around what sort of actions and what sort of messaging is going out to the community with regards to that completely unwarranted and appalling xenophobia and racism that's emerging in this crisis. That's probably for Annalise, I think, maybe.
Yeah, sorry, you've caught me as I was about to sneeze.
That's all right. Apparently I've been coughing, which some questioners have noticed as well.
Yeah, look, that is and remains completely unacceptable. And there was a lot of messaging around that earlier, and it's probably dropped off a little bit now. But I would agree, there's been some concerning reports again in the last week or two that have emerged around that. So we obviously unequivocally condemn that kind of behaviour. But what I might do, I haven't seen that particular one about Geelong, but that's awful. And I think it would be an opportune time now. And look, again, I suspect this is being flared by some patently ridiculous conversations about suing China and wet markets from people who clearly don't know what a wet market is, because, you know, South Melbourne is a wet market, and other things that are going on in the media now that the attention of, you know, now that we're not having exponentially increasing case numbers every day, they're looking for something else to talk about or someone else to blame for the current situation. So I think it is a good time to have another look at what our messaging is saying around that, and I'll take that on note and feed that back to the comms team to see if we can get some more messaging out around that.
That's great. Anita, I'll hand over to you.
Thanks very much, Cam. I'm just aware that there have been a few questions about MBS billing numbers. I know that Cameron is going to speak to some of those points towards the end of this webinar. We're talking to Department of Health and Human Services Victoria, which is not you know, the government body that's responsible for MBS item numbers. So we're going to park the billing to the very end with Cam. But Annalise, there is some concern amongst GPs as clinicians. What should we do in the instance that we are aware that a healthcare worker has been recommended that they test or that they self-isolate because of symptoms, and we know that that person is choosing to continue to attend work? Do we have obligations to make any reports? And if they're not necessarily AHPRA regulated practitioners, how do we go about doing that?
Yeah, look, that is a really tricky one. At the moment, from a purely regulatory perspective, we have a direction on cases that people must isolate. So if practitioners are aware of patients or colleagues or other health practitioners who are known to be cases and who are not undertaking home isolation, then that can absolutely be reported through the there's an option on the 1300 number to report non-compliance. If people are known to be contacts and have been identified by the department as a close contact and required to quarantine due to that, there is not currently a direction for that. but we are considering changing that as one of the suite of things that we look at going forward to really sort of strengthen that from that to be, we consider it to be a requirement, but to make it an actual legal requirement. In terms of people working while symptomatic, I think, look, the first thing that I would do is try and speak to them, try and resolve it if you can, if they're a colleague or a friend. But at the moment, there isn't a reporting mechanism around that. We're sort of relying on healthcare workers really doing the right thing and what they know to be professionally appropriate. But that middle ground between when somebody is symptomatic but they're not actually a known contact is a bit of a grey area at the moment. So it's something that we can look at and consider. I'm just not sure from a legal perspective whether we would have the capacity to put on you must stay home when you've got symptoms, because it's kind of a difficult thing to really objectively speak about. I think AHPRA is a tricky one because nobody likes, talking about AHPRA from that kind of thing, and it's hard to know. There's always going to be a spectrum. It's hard to know where on that spectrum that kind of stuff remains. Obviously, if somebody has got symptoms and has been tested, the requirements are that if you're being tested, you have to stay at home until you've got a result. So I think it's pretty clear there. Like if somebody goes to work between being tested and getting a test result, that's pretty grossly unacceptable actually at this point in time of the outbreak, when we know all that we know about now. Whereas, somebody who's normally got hay fever and has a sneeze at work, and then, so there's a real balance there. So I suppose that's a very long-winded way of saying there are some regulatory and reporting aspects that people can undertake when there's really, really gross, blatant disregard for what the current rules are, particularly in terms of cases who are known to be cases, returned travellers, and at some point soon probably close contacts who've been identified and told by the department, and people who are being tested, but people who should be being tested and are not, or who should not be at work because they're symptomatic. There's not a reporting mechanism into us, so I suppose my recommendation would be, as a starting point, to have the discussion with them personally, and if that's not possible, then perhaps discuss it with their employer if they're putting their workplace at risk.
Just with the very short amount of time we've got left before I hand back to Cam, we do have GPs wanting to know whether it is their role to be testing children who might meet the case definition.
Please do. Yep. We don't know much about kids. We know that they get snotty and get respiratory tract infections all the time, but they were deliberately included in the case definition. And the more we understand about how kids factor in this, the better it's going to be able to inform our ability to figure out how to manage this and what to do about schools and remote learning or not remote learning, and what role kids have in transmission dynamics. So if you can, yep.
And one of the other questions, there was sort of or perceived to be a suspension of doing ear, nose and throat exams, or particularly hold off until proper PPE was available. What is the advice now about ear, nose and throat exams in general practice?
Look, again, I suppose if somebody meets the clinical case criteria, which now everybody with an ERTI does, we would recommend trying to use PPE when you're doing the examination, if you can, or trying to maintain the alternative mechanisms that you've put in place at this point in time. But if you're going to do an aerosol generating, if you've got a kid that's coughing all over you, that's obviously going to generate a degree of droplets. So I would be trying to be sensible about that kind of thing if you possibly can, knowing that it's quite difficult. I suppose the balance being, there is going to be a very low prevalence in our general population at this point in time, and we're hoping it stays that way. But we wouldn't recommend taking chances if you can possibly avoid it.
Just one last clinical question before we hand over to sort of some more logistical and billing questions. Thanks, Annalise. There is still some confusion. If you could let us know, in a patient who has respiratory symptoms but who has returned a negative COVID test, should they remain self-isolated until 3 days after their respiratory symptoms have resolved?
Yes. Yep. And look, with the current self-isolation rules anyway, most people should be at home for most of the time if they possibly can. But yeah, we would recommend that at this point in time.
Thank you so much. It's been such rich information. Appreciate it. I'm going to hand back to Cam now, who's going to deal with some of the other nitty-gritty questions from today.
Thanks, Anita. So this obviously is a federal issue when we're talking to DHHS in Victoria, and the national rollout of some of the funding mechanisms for general practices obviously been quite iterative and rolling as it goes forward. I think most of us have seen that we as GPs got left off the removal of bulk billing for the defined vulnerable group, which I think was section 8.4 of the determination, if I'm not mistaken. But today there was an announcement that there is a new bulk billing incentive item that has been introduced where the service is to a vulnerable patient, so specifically to a vulnerable patient. So for metropolitan GPs, that number is 10981, and of course I wrote the number down for rural areas and have promptly forgotten it and misplaced it, but it will be available somewhere. So the bulk billing incentive as it stands is still there. So that's for under 16-year-olds and for concessional beneficiaries, but there is a new one for patients who are considered vulnerable. And just to remind us of the vulnerable definition, it's a person who's required to self-isolate or quarantine in accordance with the guidance issued by the Australian Protection Principle Committee, someone who is at least 70 years old, or if the person identifies as being Aboriginal or Torres Strait Islander descent, is at least 50 years old, or is pregnant, or is the parent of a child aged under 12, or is being treated for a chronic health condition, or is immunocompromised, or meets the current national triage protocol for suspected COVID-19 infections. That definition is available on the site. You can find it pretty easily. So that means that if you're seeing a patient in that group, whether it's face-to-face, via video or by telephone, you can add one of the new bulk billing incentive items. So this is an incentive that's going to be on to groups that otherwise probably wouldn't have got it. And obviously there's some still questions that I have around the definition of a chronic disease. And Anita's just reminded me that the rural number is 10982 and the metro number is 10981. Obviously it's just come out, it's fairly new. I think there's still some things for us to work through, but I think it's important that we know and we start using it because the start date was today. Just so everyone is aware, we missed the first 10 minutes of the recording. Something glitched in the background. We're going to try and salvage that, but if we can't, that will be lost. So it's not that you can't. So you can't bill, as far as I'm aware, you can't bill the current existing bulk billing incentive and the new bulk billing incentive. It's one or the other. So there's still going to be a little bit of work on this. So just keep your ear to the ground because it does give us a little bit, although I would have preferred that we got left off, that we weren't left off the removal of bulk billing for the defined vulnerable group, as it seems every other health professional that can access Medicare, whose patients can access Medicare benefits for their services, had it removed today. So thank you again. I know we've gone a little bit over time, but we started a little bit late. The next webinar is next week on Monday, the 27th of April, 6 to 7 p.m. We're going to have an invite in the daily bulletin that the RACGP has released, and we'll try and post it online in various places so you can also log on. We've got 4 of these, so next week, the 4th of May and the 11th of May, and I'm guessing by the 11th of May we'll have some news as to what happens next, I guess, and hopefully we can all continue to do what we're doing. Just again, note that there is handouts in the control panel. That's the slides from DHHS today. So Karen has just sent a message to all. Thank you all for joining. There'll be some automatic CPD in this webinar, except for the first 10 minutes, will be available online when we upload it. Thank you again. I think these sessions are fabulously useful, and we're getting a lot of information out of DHHS. And again, I thank the Chief Health Officer and the Chief Health Officer's office for all of their work, because clearly we are in a much, much better place than we may have otherwise been. And good on all Victorians for doing what they're told. Thank you, and I'll see some of you next week. Bye-bye.